Welcome to the deep dive. Today we're tackling Brachiocephalic Artery Disease. Sounds a bit complicated, I know.
It does, but we're focusing on those really key blood vessels, the ones branching right off the top of the aorta.
Right, the innominate left common carotid, left subclavian. Think of them as like the major highways for blood going to your head and arms.
Exactly. You might also hear them called the supr-aortic trunks, or sometimes the great vessels.
Got it. And to really get into this, we've got some serious resources. Chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
That's pretty much the gold standard in vascular surgery. So yeah, this is expert-level stuff we're digging into.
Absolutely. So our mission today, for you listening, is to pull out the key info from Rutherford's about this disease and, importantly, how surgeons actually go about fixing it.
We want to make it clear, insightful, basically help you understand what these conditions are, why they matter for your health, and the main ways they're treated.
Without getting totally bogged down in the medical jargon, all right?
Right. So let's start with the basics. The most common issue we see in these arteries is atherosclerosis.
Okay, that's the plaque buildup, right? The narrowing or blockage, like rust in a pipe.
Exactly like that.
Yeah.
But, it's not the only thing. We also see aneurysms.
Or the artery wall kind of balloons out.
Precisely. And dissections, where the layers of the artery wall actually tear apart. Plus, sometimes direct injuries or other less common conditions, too.
And if these arteries get narrowed or blocked, what happens then? What are the consequences?
Well, it can cut down blood flow to your arms. That might cause pain, maybe increase the risk of clots forming.
Okay. And more seriously?
More seriously, it impacts blood supply to the brain. That can lead to a stroke, or maybe a TIA, a transient ischemic attack.
The so-called mini stroke.
That's the one. And, though it's rare, sometimes these issues can physically press on things nearby, causing compression symptoms.
And you mentioned something specific for people who've had heart surgery.
Ah, yes. If you've had a heart bypass using an internal mammary artery graft, a problem upstream in these brachiocephalic arteries can sometimes cause something called coronary steal.
Steal, meaning blood gets diverted away from the heart.
Exactly. Away from where it's needed. So it's definitely something to be aware of.
Okay, let's maybe dig a bit deeper into the anatomy here. How do these arteries normally branch off the aorta?
So the textbook pattern, let's call it, where the innominate, the left common carotid, and the left subclavian each come off the aortic arch separately.
That's the normal way.
Well, it's what many consider normal, but it's actually only present in about, say, 70 to 75% of people.
Only 70 to 75%. Wow. So variations are pretty common then.
Oh, very common.
Yeah.
And this is where it gets really interesting.
Okay.
The most common variation, you see it in maybe 21 to 27% of us,
Here.
is what's known as the bovine arch.
Bovine arch. Does that mean it looks like a cow's?
Huh? No, not at all. The name is totally misleading. It just means the first two branches, the innominate and the left common carotid, they share a common starting point before they split.
Ah, okay. So they come off together initially. That's a big chunk of people, 21 to 27%.
It really is. It shows that what we think of as the standard arterial map is actually, quite diverse. And that has huge implications for doctors.
Right, because you need the right map for the right person, essentially, like different navigation apps for different cities.
That's a great analogy. And there are other variations too, though they're less frequent.
Like what?
Well, in about 3 to 4% of people, the left vertebral artery that supplies blood to the back of the brain, it actually comes directly off the aortic arch. Normally, it branches off further down.
Okay.
And then there's something called an aberrant right subclavian artery, or ARSA, seen in maybe 0.8 to 1% of people.
Aberrant meaning it's in the wrong place.
Sort of. It originates further along the arch after the left subclavian artery and then often crosses behind the esophagus. It's actually seen a bit more often in women.
Huh. And that's linked to how the arch develops.
Yeah, it seems to be linked to some subtle differences in how the aortic arch forms way back in embryonic development.
It's incredible, the variability. And you mentioned ethnic patterns, too.
Yes, there seem to be some differences. Studies suggest these variations might be a bit less common in people of Asian descent.
Okay.
Whereas the bovine arch, that shared origin we talked about, seems to pop up more frequently in individuals with African and South American ancestry.
Fascinating. So for doctors, knowing about these variations isn't just trivia, it's critical.
Absolutely critical. Imagine planning a surgery or an endovascular procedure. You need to know the exact layout of those arteries.
Like needing the right blueprint before you start working on an engine?
Precisely. Knowing what's normal for that specific patient and what variations might be there is step one for diagnosis and treatment planning.
Okay, so how do doctors figure all this out in a specific person? What's the diagnostic process look like?
It always starts with a good physical exam, carefully feeling the pulses in the neck in both arms.
And blood pressure, too.
Definitely. Measuring blood pressure in both arms is key. A significant difference between the two arms can be a real red flag.
Suggesting a blockage on one side, maybe in the subclavian artery?
Exactly. Or pulse strength differences. That's another clue.
And after the physical exam, what comes next? Tests.
Usually non-invasive imaging studies. Carotid duplex ultrasound is very common.
That uses sound waves.
Right. It lets us see the blood flow in the carotid arteries in the neck and the vertebral arteries, too. We can measure flow speed, see if there's narrowing.
Can it pick up things like that subclavian stele you mentioned?
Often, yes. If blood is being stolen from the brain to feed the arm, the ultrasound might show the blood flowing backwards in the vertebral artery.
Wow, okay. And for the arms themselves?
We can do studies like pulse volume recordings or PVRs and segmental pressures. These help quantify how much the blood flow might be reduced in the arms.
So those give a good initial picture, but I imagine sometimes you need more detail, a clearer map.
You're exactly right. For the definitive diagnosis and planning, we usually turn to axial imaging.
Meaning CT scans or MRIs.
Specifically, CTA computed tomography angiography, which uses contrast dye and MRA, magnetic resonance angiography. These have really become the main tools.
And they give those 3D views.
Yes, detailed 3D maps of the arteries. They have largely taken over from the older, more invasive procedure called conventional aortography.
Makes sense. Better imaging, less invasive? Are there any downsides to CTA or MRA? Limitations?
Well, they each have pros and cons. With CTA, sometimes heavy calcium deposits in the artery walls, which are common with atherosclerosis, can make it a bit tricky to see the exact degree of narrowing underneath.
Okay, the calcium gets in the way of the view.
A bit, yeah. And MRA, while it's great because it doesn't use radiation and shows soft tissues well, can sometimes be affected by very slow or turbulent blood flow. Or if the patient moves during the scan, that can occasionally make the narrowing look worse than it is.
But MRA has an advantage for the brain.
Yes, a big advantage is you can often get detailed images of the brain at the same time, which is obviously very relevant if stroke is a concern.
So it's kind of a trade-off depending on the situation. Is CTA maybe better for looking right near the heart at those main branches?
Generally, yes. CTA tends to be faster, and it really excels at showing the structure of the vessel wall itself, the characteristics of the plaque. It's particularly valuable for assessing the ascending aorta and those first branches, the supr-aortic trunks.
To see if they're suitable for surgery, maybe.
Exactly, to figure out if a direct repair is feasible or if maybe a bypass approach would be better.
Are there any other imaging tools used sometimes?
In specific situations, yes. PE or transesophageal echocardiography.
That's the ultrasound probe down the throat.
Right, to get a close-up view of the heart and aorta from the inside.
Yeah.
And also intraoperative epiaortic ultrasound, where the ultrasound probe is placed directly on the aorta during surgery.
Ah, for real-time guidance during the operation.
Precisely.
Hmm.
Especially helpful for planning where to clamp the aorta safely.
Okay, great overview of diagnosis. So we know what can go wrong, how we find it. Now, the big question. When do doctors decide to actually intervene for occlusive disease for those blockages?
That's the critical decision point.
Mm-hmm.
And interestingly, while atherosclerosis is the most common cause of narrowing,
The plaque buildup again.
right, it's not actually the most frequent reason we see major clinical problems, specifically in the innominate artery or the left common carotid artery.
Oh, where is it more common then?
The subclavian arteries, the ones supplying the arms, seem to get hit with significant narrowing more often.
Interesting. And who typically gets these atherosclerotic problems in these specific supra-aortic vessels?
The typical patient presenting with symptoms is often, say, in their early 60s, frequently Caucasian, usually with a history of smoking.
And other standard risk factors, like high blood pressure, cholesterol.
Exactly.
Mhm.
High blood pressure, high cholesterol, diabetes, the usual suspects for atherosclerosis. And it's also quite common, maybe 20 to 40% of the time, for patients to have significant disease in more than one of these major vessels, multi-vessel involvement.
Okay. But it's not always atherosclerosis causing the blockages, right? You mentioned other causes.
Correct. We also see non-atherosclerotic causes, things like giant cell arteritis and Takayasu disease.
Those are inflammatory conditions?
Yes, inflammation of the artery walls that can lead to severe narrowing, even complete blockage. Takayasu arteritis is particularly relevant here.
Why Takayasu specifically?
because it really likes to affect these supr-aortic trunks. It actually accounts for a good chunk of the case in needing surgery for non-atherosclerotic reasons. It typically affects younger women, often in their 20s or 30s.
And it's more common in certain parts of the world?
Yes, higher incidence reported in the Far East. Another thing to consider is radiation-induced arteritis.
From cancer treatment, maybe?
Exactly. It can develop years after radiation therapy to the chest or neck area, causing scarring and narrowing of the arteries.
So, quite a few ways these arteries can get blocked, but what actually triggers the decision to step in and fix it is just seeing a blockage on a scan enough?
Not usually, no.
Yeah.
The main driver for considering revascularization, that means restoring the blood flow, is the presence of symptoms.
Okay. What kind of symptoms?
Neurologic symptoms are a big one. A full stroke, or those mini strokes, the TIAs. That happens in a pretty high percentage, somewhere between 50 and 90% of symptomatic patients.
Wow, that's high. And arm symptoms.
Yes, symptoms affecting the arms, like claudication pain when you use your arms, or even pain at rest. That's seen in maybe 10 to 40% of cases.
And don't forget the Steele syndromes.
Right. Subclavian steal, where blood flow gets diverted away from the brain, the vertebral steal, or even for the heart, the coronary steal, if they have those internal memory grafts.
Yeah.
Those are definite indications too.
So what if someone has, say, a 70% blockage found on a scan, but they feel perfectly fine, no symptoms at all?
Generally, for asymptomatic lesions, the approach is conservative. Medical management.
Meaning medications.
Right. Controlling blood pressure, cholesterol, maybe antiplatelet drugs like aspirin to reduce clot risk. Careful monitoring.
But are there exceptions? Times when you might fix an asymptomatic blockage?
Yes, there are a few specific situations. For instance, if there's a significant blockage in an innominate or subclavian artery that's right near where someone needs dialysis access put in, or where a bypass graft for their leg originates.
To make sure those accesses or grafts work properly.
Exactly. Need good inflow.
Yeah.
Similarly, if there's severe disease right near where an internal mammary artery graft is planned or already exists for heart bypass,
Okay, protecting the heart graft.
or sometimes if the blockage is so bad it's making it really hard to get an accurate blood pressure reading in that arm, which messes up overall blood pressure management.
Ah, that makes sense.
And of course, if an attempt was made to fix it with less invasive endovascular methods, balloons, stents, and that failed, then open surgery might be considered even without symptoms.
Okay, that covers occlusive disease well. But we mentioned other potential problems too. Let's touch on those other indications for needing surgery, like trauma.
Right. Trauma to the chest or neck can definitely injure these major arteries. It can range from just a small tear in the inner lining, an intimal injury, all the way to a complete transection, a full tear through the vessel.
And the symptoms would depend on how bad the injury is.
Entirely. Could be sudden loss of blood flow to the arm, pain, paleness, no pulse, or neurologic problems if brain blood flow is hit, or even compression of nearby structures in the chest or neck if there's major bleeding.
Is blunt trauma common here, like from a car crash?
It happens, but blunt injuries are actually less common in these specific supra-aortic trunks compared to the part of the aorta further down. These vessels are a bit more protected.
So penetrating trauma is more likely gunshots, stabbings.
Yes, unfortunately, penetrating trauma is a more frequent cause of injury to these particular vessels.
And how are traumatic injuries managed? Is it always surgery?
If there's active severe bleeding, or the arm's blood supply is critically cut off, or there's compression happening, then yes, urgent surgical repair is absolutely needed. Stabilize the patient, stop the bleeding, restore flow. That's the priority.
What about less severe injuries?
For smaller asymptomatic injuries, like maybe just an intimal flap, the approach might be medication blood thinners and very close observation with follow-up imaging, watching to make sure nothing worse develops.
And surgery might come later if needed.
Right. If new symptoms pop up, or if clots keep forming despite medication, or if a pseudoaneurysm, like a contained leak or bulge, develops and starts getting bigger or causing problems.
Okay. What about dissections, where the artery walls tear?
Dissections can happen spontaneously, maybe linked to high blood pressure or certain genetic conditions affecting connective tissue. Or they can spread upwards from a dissection starting in the aorta itself.
And the danger there is stroke.
If the dissection involves the common carotid arteries, yes, there's a significant risk of stroke, either from reduced flow or from clots forming in that torn channel. Even after the main aortic dissection is fixed, sometimes the dissection in these branches can linger and cause trouble.
What about dissections just in the subclavian artery?
Those can cause problems too. Issues with blood flow to the back of the brain, vertebrovascular insufficiency, or arm ischemia, or even, again, heart issues if those mammary grafts are involved.
How are dissections usually treated first?
Usually with medical management first. Antithrombotic meds, blood thinners, antiplatelets for several months. The goal is to prevent clots and stop the dissection from spreading further.
And surgery is reserved
For specific complications, like if the dissected artery actually ruptures,
Yeah.
or if a pseudoaneurysm forms,
Right.
or if there's a mobile clot inside that looks like it could break off and go to the brain.
Or if it just keeps getting bigger fast.
Exactly. Rapid enlargement. Or if it causes persistent, severe narrowing despite the medications, then surgery might be needed.
Got it. And we also talked about aneurysms, the ballooning parts.
Right. True. Isolated aneurysms just in these proximal brachiocephalic arteries are actually pretty rare. When they do occur, it's most often in the subclavian artery.
And they're often linked to other issues.
Yeah, frequently associated with aneurysms higher up in the aortic arch itself, or sometimes related to things like thoracic outlet syndrome, that compression between the collarbone and first rib.
And in younger patients?
In younger folks who get these, it's important to think about screening for underlying genetic connective tissue disorders like Marfan or Ehlers-Danlos syndromes, which can weaken vessel walls.
What kind of problems do these aneurysms cause? Can you feel them?
Sometimes they're found completely by accident on an imaging scan, no symptoms at all, but they can cause localized pain chest, arm, back, neck.
And the risk of clots.
That's a major concern. Clots can form inside the aneurysm sac and then break off, travel downstream.
Causing a stroke or blocking flow to the arm.
Precisely. Larger aneurysms can also mess with blood flow hemodynamics, maybe affecting the back of the brain, or they can physically compress nearby structures, windpipe, esophagus.
So if an aneurysm is causing symptoms, it needs fixing.
Generally, yes. Symptomatic aneurysms should be repaired. Even smaller, asymptomatic ones might be considered for repair because of that ongoing risk of throwing clots, thromboembolism.
You mentioned something specific with that aberrant right subclavian artery, too.
Ah, yes, the comoral diverticulum.
Mm.
That's a specific type of outpouching at the origin of an RSA, right where it comes off the aorta. And that diverticulum itself can become aneurysmal and require treatment.
Okay. And finally, infection. Not common, but it happens.
Rare, but yes. Certain infections like syphilis or tuberculosis historically could weaken artery walls and lead to aneurysms, especially in the subclavian.
And bacteria can infect existing problems.
Right. If an artery is already damaged, bacteria floating in the bloodstream can latch on and cause an infected aneurysm or mycotic aneurysm. Very dangerous.
Any other weird infection scenarios?
Well, with an RSA crossing behind the esophagus, very rarely a fistula, an abnormal connection, can form between the artery and the esophagus. Extremely serious. And another rare but critical one is a trachea innominate fistula.
Between the windpipe and the innominate artery?
Yes, it can happen sometimes after someone's had a breathing tube or a tracheostomy in place for a long time, causing erosion. That's a surgical emergency.
And infected aneurysms always need fixing.
Generally, yes. Regardless of size, infected aneurysms typically need surgical repair, combined with a long course of antibiotics to try and clear the infection.
Okay, we've covered a huge range of problems. Let's shift focus now to the solutions. How do surgeons actually fix these things? What are the general strategies for revascularization?
Well, the most important thing always is the individual patient, their overall health, any other medical issues they have, comorbidities.
And their specific anatomy, right, including those variations we talked about.
Absolutely. The precise anatomical details are crucial. And we're also seeing, a real increase in using hybrid procedures.
Hybrid meaning mixing open surgery and less invasive techniques.
Exactly. Strategically combining traditional open surgery with endovascular methods, using catheters, stents, balloons. It's about having more tools in the toolbox, yes, but also understanding how to blend them for the best outcome, with the least risk for that specific person.
A more personalized approach.
Very much so.
Are there sort of broad categories of surgical approaches, like chest open versus neck only?
Yes, that's a key distinction. For patients who are considered higher risk, maybe older, sicker, we often prefer extra-anatomic cervical revascularization.
Meaning bypass is done just in the neck, avoiding the big chest incision?
Precisely.
What?
While the transthoracic approaches, which involve opening the chest, usually through sternotomy, to get direct access to the aorta and its branches.
Those are for tougher cases. Or younger patients.
Generally, yeah. Reserved for younger, fitter patients or for more complex situations, maybe multiple vessels are diseased or the aorta itself needs work.
What if someone needs heart surgery and has problems with these brachiocephalic arteries? Can they be done together?
Often, yes. If a patient needs coronary artery bypass surgery, for example, and also has significant disease on their supr-aortic trunks, it can be beneficial to do an anatomic reconstruction of those vessels at the same time.
Addressing both critical problems in one go.
Right. Potentially less overall burden on the patient. And one other scenario is supr-aortic debranching.
Debranching, what's that for?
It's sometimes done before a TEVAR procedure, that's thoracic endovascular aortic repair, using stents to fix the descending aorta. Debranching basically reroutes the blood flow to the head and arms from the arch.
Using bypass grafts.
Yes, usually bypass grafts originating lower down, maybe from the ascending aorta. This creates a better disease-free landing zone higher up on the arch for the main TEVAR stent graft.
Okay, let's dive into the specifics, starting with transthoracic revascularization, opening the chest. What are the main techniques there? Endarterectomy.
Endarterectomy is one option.
Yeah.
That's where you surgically open the artery and physically remove the plaque buildup from the inside lining.
Like scraping the rust out.
Yes, exactly. It works best for very specific, localized blockages that don't involve the aortic arch itself, but
Okay.
it does carry risks, maybe a 3–7% risk of stroke, 5–7% mortality in some older series. And because disease often does involve the aorta nearby, it's actually not performed very often on the innominate artery itself.
And there's a clamping risk, too.
Yes, when clamping the innominate artery to do the endarterectomy, there's a potential risk of disrupting flow to the left, common carotid artery, if it originates nearby or shares a trunk.
So bypass grafts are maybe more common when you're opening the chest.
Yes, bypass grafting is definitely more common for transthoracic repairs. This involves creating a new route for blood flow around the blockage using a graft.
Usually a synthetic graft, like Dacron or PTFE.
Yes, those materials are designed for this strong, compatible with blood flow. The inflow, where the graft starts, is typically sewn onto a healthy spot on the ascending aorta, the part coming right out of the heart.
And you need good imaging beforehand to plan that.
Oh, absolutely crucial. Preoperative CPA is essential to map everything out where the disease is, whereas a safe place on the aorta to clamp and attach the graft, like construction blueprints for that detour.
And you can configure these grafts in different ways. Aorta to innominate, aorta to carotid.
Exactly. Aorto-innominate bypass, aorta-carotid, aorta-subclavian, or even more complex setups using branch grafts to supply multiple vessels from a single aortic origin.
Do those pre-made branch grafts always work well?
They can, but sometimes surgeons worry about kinking or trouble closing the sternum over them. So sometimes they might prefer to sew a main graft, say, to the innominate, and then attach smaller jump grafts off that to supply the other vessels as needed, tailoring it.
Okay. What if the disease is really extensive, involving the whole aortic arch?
Then you're looking at a much bigger operation, total aortic arch replacement.
That sounds major.
It is. Requires putting the patient on the heart-lung machine, cardiopulmonary bypass, cooling the body way down deep hypothermia to protect the brain.
And you need special ways to keep blood flowing to the brain during that.
Yes. Specialized techniques like antegrade cerebral perfusion, pumping blood directly into the carotid arteries, or sometimes retrograde perfusion through the veins. A special branched graft is then used to replace the entire diseased arch segment, reattaching the origins of the head and arm vessels.
Wow. So these transthoracic operations, they sound effective but risky. What are the typical outcomes?
Historically, these carried very high risks. Things have definitely improved a lot with better techniques, anesthesia, intensive care.
But still not minor surgery.
Definitely not. There are still potential risks: stroke, heart attack, death. The rates vary in different studies, but they're negligible. Long-term patency, how well the grafts stay open, can be very good in the right patients, younger, fitter people.
But probably not for asymptomatic patients, given the risks.
Generally, no. The risk-benefit balance usually doesn't favor such a big operation if there are no significant symptoms.
And recovery, what's that like after opening the chest?
It's intensive. Very careful management right after surgery is key. Strict blood pressure control is vital to protect the new grafts. Close monitoring of heart, lungs, getting patients moving early helps prevent complications.
ICU stay.
Typically, yes. And making sure the sternum, the breastbone, heals properly is really important to avoid infection or instability. Then long-term follow-up is needed.
Checking the grafts with ultrasound.
Right. Regular physical exams and duplex ultrasound scans to check the blood flow. CTA scans are usually reserved for if there's a specific concern or a change on the ultrasound.
Okay, let's switch gears now. Talk about those extra anatomic options, the ones done in the neck, avoiding the chest opening. You mentioned subclavian carotid transposition, SCT.
Right, SCT. It's a really effective and often very durable procedure specifically for fixing a blockage near the start of the subclavian artery. It gets compared a lot to carotid subclavian bypass.
How does it work? Transposition means moving something.
Exactly. Instead of using a graft, the surgeon divides the subclavian artery close to where it comes off the aorta, and then directly reimplants it, sews it, onto the side of the nearby common carotid artery in the neck.
So you're essentially rerouting the existing artery. No synthetic tube needed.
Correct. Using the patient's own artery. That can be an advantage for long-term durability, maybe less risk of infection.
But it's not for everyone.
No. It's generally not done if the patient has had a coronary bypass using their internal mammary artery, because you have to clamp the subclavian temporarily, which could cut off heart blood flow.
Okay, need to protect that graft.
And you also need to look closely at the vertebral artery anatomy beforehand. Make sure rerouting the subclavian won't cause problems with blood flow to the back of the brain.
So it's elegant using the patient's own tissue, but has some specific limitations. How's the surgery done?
Usually through a single incision in the neck, just above the collarbone, the clavicle. The surgeon carefully finds and isolates the common carotid and the subclavian arteries.
And the crucial step.
A really critical step is securely closing off the stump of the subclavian artery where it was cut off from the aorta, usually ligated or oversewn. You absolutely don't want that bleeding back into the chest later. Then the free end of the subclavian is brought over and sewn neatly onto the side of the carotid.
Okay. Now, what about the other common neck procedure, carotid subclavian bypass, CSB?
Yes, CSB is actually the most frequently performed cervical extra-anatomic bypass. It's really versatile. It can be used for various problems affecting the chest outlet, the supr-aortic trunks, even the neck arteries themselves.
And it uses a graft.
Yes, this one uses a prosthetic graft, again, usually Dacron or PTFE, to create a connection, a detour, between the common carotid artery and the subclavian artery, usually further out in the neck or below the clavicle.
Can you do anything if the carotid artery itself, the inflow source, is a bit narrowed?
Sometimes, yes. With endovascular techniques now, if there's a moderate narrowing in the common carotid, it might be possible to put a stent in there first or at the same time to optimize the flow into the bypass graft.
Interesting. And you mentioned for this bypass, synthetic grafts might actually be better than using a vein.
For this specific location, carotid subclavian, yes. Studies have generally shown that prosthetic grafts tend to stay open longer, have better long-term patency compared to using the patient's own saphenous vein from their leg.
So even though it's synthetic, CSB is still a good, durable option.
Absolutely. While some head-to-head comparisons suggest SCT might have slightly better long-term patency in certain studies.
CSB is more versatile.
Exactly.
Yeah.
You can use CSB in a wider range of anatomical situations, like if the vertebral artery anatomy makes SCT tricky, or if you definitely need to preserve that internal mammary artery for future heart surgery options.
And the connections are usually end to side.
Yes, the graft is typically sewn end to side onto both the carotid and the subclavian. And usually, you don't need to tie off the subclavian artery proximal to the bypass.
Are there other bypasses that can be done just in the neck?
Yes, another important one is carotid-carotid bypass.
Connecting one carotid to the other, when would you do that?
You'd consider that if neither subclavian artery is a good source for inflow, maybe they're both diseased. So, you run a graft between the two common carotid arteries in the neck.
How do you route the graft?
Usually it's tunneled behind the pharynx, the back of the throat. That's generally preferred over tunneling it under the skin in front.
Why behind?
The retropharyngeal rate helps avoid potential problems like the graft eroding through the skin later on, and it also keeps the front of the neck clear in case the patient ever needs a tracheostomy or even a future sternotomy.
And does that work well long-term?
Yes, the reported long-term patency rates for carotid bypass are generally quite good.
What if the carotids themselves aren't good inflow sources? Are there options that bypass them completely?
There are, though they're used less often. Axilloaxillary bypass is one.
Armpit to armpit.
Exactly. Connecting the two axillary arteries under the armpits with a graft tunneled across the chest under the skin. It's mostly used for arm symptoms or sometimes that vertebrobascular insufficiency when other options aren't good.
Any downsides to that tunneling across the chest?
Yeah, potential for graft kinking, infection, or skin erosion over the graft. An alternative is a cervical subclavian bypass.
Connecting the two subclavians up in the neck, avoiding the chest tunnel.
Right, though less common. Axilloaxillary bypass despite the tunneling, has actually shown pretty good long-term patency in studies.
Wow. Okay. So it seems like a really adaptable toolkit of extra anatomic options. How do the results generally stack up? Cervical procedures versus the big transthoracic ones?
Generally speaking, these extra anatomic cervical bypasses tend to have lower immediate risks, lower rates of perioperative stroke, heart attack, death, compared to opening the chest.
That makes sense. Less invasive.
But the flip side is that the long-term patency, how long these bypasses stay open over many years, might not be quite as consistently high as a well-done direct anatomic repair coming off the aorta.
So a bit of a trade-off again. Risk versus long-term durability.
Exactly. And we're definitely seeing a trend now towards using endovascular methods or hybrid approaches or these extrathoracic bypasses as the first line of treatment for many patients.
Reserving the big transthoracic operations for.
Or for select cases, younger, fitter patients with really complex multi-vessel disease where that direct anatomic repair might still offer the absolute best chance for a very long-lasting result.
One last thing on procedures. What if someone needs both a carotid fixed and one of these supr-aortic trunk reconstructions? Do surgeons often do both at the same time?
Yes, that's not uncommon at all. Atherosclerosis often doesn't stick to just one spot. Up to maybe 30% of open supr-aortic trunk surgeries also involve doing a carotid endarterectomy, cleaning out the carotid artery at the same time.
Did doing both together increase the risk much, especially stroke risk?
That was a concern based on some older studies. But more recent data, looking at large groups of patients from national databases, seems to indicate that, in experienced hands, adding a carotid endarterectomy doesn't significantly bump up the overall risk of stroke, death, or heart attack compared to doing the SAT reconstruction alone.
That's reassuring. And the recovery after these neck surgeries, is it different from the chest surgery recovery?
Yes, generally less intensive. The focus right after is still on careful blood pressure control, making sure the patient takes deep breaths and coughs to keep their lungs clear.
Pulmonary toilet.
Right, and getting them moving early. Aspirin and maybe other antiplatelets are usually started pretty quickly.
Any specific things to watch for after neck surgery?
We often get a chest x-ray afterwards to check for any potential phoretic nerve injury, which could affect breathing, though it's uncommon. Monitor the drain sites for any lymphatic fluid leak, and watch for hoarseness or eyelid drooping, which could suggest nerve irritation.
And long-term follow-up is similar, ultrasound checks.
Yes. Regular physical exams and duplex ultrasound to monitor the bypass or transposition. Again, CTA is usually just if there's a clinical concern or the ultrasound shows something changing.
Okay. Well, we have certainly navigated a complex area today. Brachiocephalic artery disease, its diagnosis, the many variations, and the surgical treatments. Let's try and recap the key takeaways for everyone listening.
Absolutely. I think the first thing is that brachiocephalic artery disease isn't just one thing. It covers a range of conditions: atherosclerosis, trauma, dissections, aneurysms, infections, each with different causes and implications.
And the solutions are just as varied, from major open chest surgery, direct repairs off the aorta.
To these less invasive extra-anatomic bypasses done entirely in the neck. Each approach has its own pros, cons, risks, and benefits.
And we can't forget those anatomical variations. The bovine arch, the aberrant subclavian, they're common and really matter for planning.
Critically important to recognize those for safe and effective diagnosis and treatment.
It really highlights how complex these decisions are. It's not one size fits all. Treatment has to be tailored to the individual.
Definitely needs expert evaluation and a personalized plan.
Which brings us to a final thought, something for you, the listener, to maybe ponder.
Given how things are constantly evolving, both the open surgical techniques and the endovascular, minimally invasive approaches,
And knowing how common these anatomical variations are.
how do you think future diagnosis and treatment for brachiocephalic artery disease might change? Could it become even more personalized, even less invasive?
And ultimately lead to even better outcomes. It's definitely a fascinating area to watch as our understanding of vascular health keeps growing, something to think about.